So good evening, everybody. Again, welcome from the EIZOC Secretariat. We are here again together for being a part of the webinar Ophthalmology Resident Teaching Series 16. ORTS will be giving us a platform for the young generation to come up with academic activities, and as a whole with this type of programs, the bond between the different states of EIZOC will be tightened. Through EIZOC, Eastern India is gaining its position and repute in the National Ophthalmic Forum. Our chairman, Scientific Committee, Dr. Sabyasachi Patnaik, has framed the webinar in a meticulous way, supported by the Chief Coordinator, Dr. BNR Subudhi sir. The program is mentored by none other than past President of AIOS, Dr. Ajit Babu Machi. The session will be moderated by Dr. Aninda Anuradha. The speaker of the evening will be Dr. Sirisha Santhil, Chief Glaucoma Service, LB Prasad, Hyderabad. We had also a galaxy of panelists who are the masters in the field of glaucoma, namely Dr. M. Siraj Ali, Dr. Sharmishta Behera, Dr. Harshita Debray, Dr. Richa Gupta. Discussions are chosen from different academic institutions across the country. Before continuing further, we'd like to hand it over to our proceedings to Dr. Pranav Ranjan, President of the EIZOC, to give the welcome address. And he will then hand it over to CSC Dr. Sabyasachi Patnaik. Over to President, sir.
Good evening, all of you. And on behalf of EIZOC, I welcome the speaker already. The secretary has taken her name, Dr. Shesta Snithil, moderator, Dr. Anindya Anuradha, panelists, Dr. Shamsita Behera, Dr. Harshita Dabrawal, Dr. M. Sriraj Ali, and Dr. Richa Gupta, and the enthusiastic bunch of discussants and the audience. EIZOC also expresses gratitude to the mentor, Dr. Ajit Babu Manji, and Chief Coordinator, Dr. BNR Subudhi, for their untiring effort for this highly beneficial program. I acknowledge the good and the hard work done by our Secretary, Dr. Swaraj Bhattacharya, and Chairman Scientific Committee, Dr. Sabyasachi Patnaik. Today's topic, surgical intervention in glaucoma, is an extremely important topic, not only for the residents, but also for every ophthalmologist. With these opening remarks, I once again welcome you all. Let's listen to today's learned speaker, Dr. Shesta Snithil, and learn from her. Over to you, Chairman Scientific Committee, Dr. Sabyasachi.
Thank you, sir. Thank you very much, respected President, respected Secretary of EIZOC. So I feel extremely happy for conducting this program that we are being successfully conducting for the last 2 years for EIZOC, and also prior to that for our Odisha State Ophthalmological Society. So I am greatly indebted to Dr. Ajit Babu Maji, who is mentoring this program very nicely and also taking a lot of care and effort in order to have this program. So I welcome today's speaker, Dr. Sirisha, and also I request her to be associated with other EIZOC activities also in future. So with this brief introduction, I hand over the program to our Chief Coordinator, Dr. BNR Subudhi sir, to carry it forward. Thank you all.
Thank you, CSC, Dr. Sabyasachi Patnaik, respected President, Dr. Pranav Ranjan, and Secretary, Dr. Swaraj Bhattacharya, and my dear colleagues. I welcome you once again to our program, ORTS 16. It's a really wonderful program. Since last few years, we are seeing how successful it is and how the postgraduate students are benefited from this program. And today, I think we are almost to end of the glaucoma series of the talks. So today, we are fortunate to get again Dr. Sirisha Santhil, who has come once before also in February. She spoke about the UBM in glaucoma. And today, she will speak at the surgical interventions in glaucoma. And of course, we got a galaxy to speak, panelists, the postgraduate students who are the basic focus or point over which we are revolving around that. So before I hand over, I will ask our moderator to introduce the speaker today. So before I ask Anindya to take over, I'll ask Dr. Ajit Babu, our mentor, to say a few words. Only one line. It's over to Dr. Ajit Babu.
Let Anindya continue. Let us not waste much time.
Okay. So it's over to Dr. Anindya to carry forward.
Thank you, sir. Thank you very much. So I can start with saying knowledge is power. Knowledge shared is power multiplied. Gaining knowledge is the first step to wisdom, and sharing it is the first step to humanity. So, welcome you all today's session. And today we have the most energetic speaker with us, and she is none other than Dr. Sirisa Senthil, Chief Glaucoma Services, LBPI, Hyderabad. Dr. Sirisa Senthil is highly accomplished ophthalmologist with over 22 years of experience in the field of glaucoma. She holds an MS in ophthalmology from Arvind Eye Hospital, Madurai in 1999, and an FRCS in ophthalmology from Edinburgh in 2000, followed by fellowship LBPI Hyderabad. She joined LBPI as faculty in 2007 and became head of glaucoma services since 2012. Dr. Senthil specializes in managing refractory adult and pediatric glaucoma with a particular interest in glaucoma drainage implants and secondary glaucoma and genetics of inherited childhood glaucoma. She has published over 169 scientific papers in peer-reviewed journal, authored several book chapters, and received multiple awards for her work. Received Best Scientific Award and Best Video Awards at GSI, AOS, and Asia Pacific Congress and WOC, including the American Academy of Ophthalmology Achievement Award 2018. We welcome you to Dr. Sirisa for today's session. I welcome our esteemed panelists, Dr. Siraj, Dr. Sarmista, Dr. Harshita, Dr. Richa, and our vibrant discussants, Dr. Anusha, Dr. Pooja, Dr. Raj, Dr. Subhasri, Dr. Sunali, Dr. Aditya for this session. And as Dr. Sarmista already mentioned, just to remind you, requesting all of you to switch on your videos throughout the session and type your questions in the chat box that we can discuss at the end. Today's topic already mentioned by our honorable chairman. So we are going to dig into surgical interventions in glaucoma. Dr. Sirisa, over to you. Thank you.
Thank you. Thank you so much. And thank you for the kind introduction, and thanks for the opportunity. So what I'm going to do is I will take you through what we are currently doing. Let's say, for example, trabeculectomy and then the implants and things like that. And I'll also touch upon the newer glaucoma surgery so that it will benefit the postgraduates, because it's possible that many of them may not be even aware of these surgeries. Today, I wouldn't say that nobody has access, because there is YouTube and there are enough number of videos and reading material and learning material. But so just give them a brief overlook so that they can go back and learn on top of it. Yeah, so we'll start. If you look at the surgical management of glaucoma, they have moved from full thickness procedures like trephination to partial thickness procedures like trabeculectomy and several modifications that have come along. Then we have moved to the non-penetrating surgeries and the MIGS and glaucoma drainage devices. So when do we choose to do a glaucoma surgery? We do a glaucoma surgery. Normally, if you look at the management of glaucoma, close to 90% of the glaucomas are managed medically today. And surgery has a role to play only in certain situations where the intraocular pressures are either not controlled very well with medications, or somebody is not able to afford medications or has side effects related to medications. So today, if we decide to do a surgery for anybody, it means that they require a good intraocular pressure control, and we need to put a stop to the progression of the disease. So we have to make sure that if we are at a situation where nothing else is helping and surgery is the last resort, then we have to be very, very sure when we do the surgery, make sure to prevent complication and also to try and make certain modifications during surgery so that it is safe in the post-operative period. And you know that in glaucoma surgery, the error between having a good surgery versus having a complication is very minimal. And if there is a complication, often, if they can be sight threatening, and one may lose the pre-existing vision as well. We also need to remember, like I said, 90% of the patients are treated medically because of the advent of newer anti-glaucoma medications that we have. Now, surgery has become a rarity. So, and trabeculectomy is the gold standard, which is there since more than 50 years now. So, if there is a procedure that is sustained for more than 50 years, you need to understand that we cannot throw that surgery away. So it is the gold standard. And what we do in trabeculectomy is that you make a conjunctival opening, you make a partial thickness scleral opening. I will run the video again. Make a conjunctival opening, either a fornix based or a limbal based. Make a partial thickness scleral flap, triangular, rectangular, whatever suits the surgeon. And then make a deep scleral block involving the peripheral cornea and a part of the trabecular meshwork and a part of the sclera, and do a large broad-based iridectomy, and the scleral flap is closed with the 10-0 nylon sutures, one or multiple based on the requirement of filtration, and the conjunctiva is closed back again with vicryl or absorbable sutures. So this is the technique that we use. This is the only surgery in, I think, anywhere in the body where you want to do a surgery, you want to create an opening and you don't want that opening to heal. But we do remember that the tendency of the body is to heal. Any injury, any wound, it tends to heal. So here in our glaucoma surgery, if there is healing, that means if there is fibrosis, it's likely that our surgery will fail. Hence, it is very, very important to prevent this fibrosis. And we do have certain medications that have really revolutionized the way the trabeculectomy outcomes are in the long term. And most important one being mitomycin C. So we use mitomycin C during trabeculectomy. The typical dose that we use is about 0.04% with mitomycin soaked sponges, which are placed in the subconjunctival space. Some people use it even subsclerally for about 1 minute, 2 minutes, or up to 4 minutes based on the risk of the surgery that we are operating. For example, if you're operating on somebody, let's say, who has a juvenile open angle glaucoma, who's a high myope, maybe you will use the mitomycin C for a lesser concentration as well as for a lesser duration, versus if we are operating somebody with a neovascular glaucoma or a pseudoexfoliation glaucoma in situations where tendency for scarring are higher, then in conditions like that, we would like to use mitomycin C, maybe 0.04% for about 3 minutes or longer. So that's what it is. And several meta-analyses have shown that the intraoperative use of mitomycin C helps to decrease the rate of failure, but with it comes the other side effects. So that is the reason why we need to keep in mind that when we use mitomycin C, we have to be very careful about how we use it, the way we apply it, as well as the way we wash it out and things like that, so that you don't end up having a hypotony and hypotony-related complications. So these are all the list of complications that you can have. So I'm not scaring you, but we need to understand that this is exactly what I told you. When we do a glaucoma surgery, it has to be really, really precise. Any deviation one way or the other, sometimes there is excess fibrosis and failure. The other way around is too much of filtration and ending up having a choroidal detachment, suprachoroidal hemorrhage, and things like that. So it has to be a balance between the two, and that is very, very important. So how do we do a safe trabeculectomy and decrease the complications while improving the long-term success? Like I said, we cannot emphasize more on the meticulousness of the surgery, wide area of application of mitomycin C. Earlier days, even when I was a postgraduate, when I was training, the training was that you make a opening of the conjunctiva in as small an area as possible and apply mitomycin exactly in that area. The thought those days was if you dissect extensively, possibly the scarring will also be very extensive and your trab is likely to fail. So it used to be that you open a very, very small area, you do a trabeculectomy and close it immediately. But I think that concept changed when Professor Penkow brought about a change in our understanding. And with his research, he has proved that wide area of application of mitomycin C. That means you do a very good dissection of the, so that will allow the bleb to form in a very diffuse way. So you don't have localized blebs, you don't have thin cystic blebs, and you have a very posterior filtering, the diffuse blebs that will prevent the problems and complications. The other modification that we have taken to, and that is possibly helping us significantly, are the use of releasable sutures or adjustable sutures. For example, in the early postoperative period, you do not want too much of a filtration, because that is the likely time when, since your bleb is still not fibrosed and the filtration is a lot, one may end up having hypotony-related complications a lot in the early postoperative period. So the idea of having releasable sutures which are very tight is to keep the sutures tight and filtration to a little lesser extent in the early postoperative period. When the fibrosis sets in or when the healing starts, and in case the pressure starts going up, we can always, in a very, very easy manner, remove one stitch at a time, so that the filtration now will increase in the, let's say, between second week to third or fourth week postoperative period, and there you can prevent the early postoperative hypotony. And other important factors that one need to remember whenever we are, so amount of filtration. Let's say if I do a trabeculectomy for 10 people, each of them I may do the surgery in a similar way. My size of the flap is same, my size of the ostium is the same, the way I put the sutures are the same, everything is the same. Still, every trabeculectomy in all these 10 patients possibly will behave differently, because a lot is also dependent not just on your surgery, but also patient-related factors. So it's very, very important to keep all those things in mind. And that is why I said, whether it is choosing a type of surgery, choosing the type of conjunctival opening, choosing the amount of mitomycin and the concentration of mitomycin that one will use, plus the number of sutures one want to place, is going to be very much dependent on the indication of the surgery. So just a short video to show you how we place releasable sutures or adjustable sutures. So basically the difference between the two is that adjustable suture is one where you do not have any loose end that is exposed outside. So they are just placed like, it's exactly like releasable sutures, but that end is cut and the conjunctiva is closed. Post-operatively, what we will do is, over the conjunctiva, catch hold of the suture and try to make a sideways movement so that the suture becomes a little looser and allows the fluid to filter. While a releasable suture is slightly different, where one of the edge of this releasable suture is outside of the conjunctival closure. So which means it is on the clear cornea. So you can do a loop releasable, you can do a straight releasable. So there are multiple types of releasables that you can do. But idea is that you make a very tight closure, but one edge of it is like a shoelace is present on the cornea. And in the post-operative period, when we require, we can just pull that knot, and that will help to release that suture and allow the additional filtration to happen. Now, post-operatively, it is very important to know, suppose we have put tight sutures, is it possible for us to modify the surgery post-operative? So to me, I always tell my patients that if I do a trabeculectomy, doing the trabeculectomy on the day of surgery is only 50% of the procedure, but how you take care of it in the post-operative period, be it the number of medications, the frequency of the steroids, post-operative bleb massage, removal of a releasable suture or a laser suture lysis, the timing of which and post-operative manipulations are going to significantly help us to improve the success of the trabeculectomy. So they are very, very important. Briefly taking you through the complications of trabeculectomy, like I said, any complication, best is to prevent it. In case you have done your best efforts, but still there is a problem or a complication, understand what are the likely problems that are there, recognize them early and treat them appropriately. So how do you evaluate a patient once a trabeculectomy is done? So to me, this is, like I said, 50% of it is what you manage post-operatively. So day one post-operatively, many times this question is asked to us, do you check IOP on day one? How? Because it's just one day post-operatively, will there be an chance of infection or a risk of infection? So don't have to worry about it. If you are using an applanation tonometer and if the applanation tonometer tip is appropriately cleaned and you are doing after the alcohol, whatever you have used to clean the prism tip is dried, then I don't think there is any problem in checking the intraocular pressure on day 1. So you have to, when you evaluate the bleb, make sure that the bleb is looked at, the location, as well as whether it is elevated or flat, whether there is any leak, how is the anterior chamber depth, is the pressure low, high, or normal. So all of this becomes very, very important. So if you don't check the pressure and you see a shallow anterior chamber, you will be confused whether that shallow anterior chamber is secondary to malignant glaucoma or whether it is secondary to a choroidal effusion that has happened and hence there is a hypotenuse. So is it high pressure or low pressure? So the decision for how to manage and what is likely to be the cause is so much dependent on the intraocular pressure. So it is mandatory to check intraocular pressure day 1 post-operatively. So there are certain guidelines that will help you to understand how you evaluate when there is low pressure, when there is high pressure. If there is low pressure, is there a leak? If there is a leak, then you know what you need to do. If it is a very tiny leak, one can use a bandage contact lens, which is of a larger diameter. Typically, we use 15.5 millimeter and leave it in the eye for at least 2 to 3 weeks and continue the topical antibiotics as long as the contact lens is on. So while doing so, you may be able to get appropriate evaluation of what is happening, and you will be able to conservatively manage it. In case the leak is a lot, or if there is a retraction of the flap, then we may need to suture it. So there are several newer surgical options that are available, and I will come to that in a little while later. Okay. So one modification that we used to do with the trabeculectomy itself, which is not possible today because this is not available. So Ologen is nothing but a collagen implant. It's made of an attylocollagen, which is used to modify the wound modulating basically instead of mitomycin C. We place that subconjunctivally over the scleral flap, and we will be, it usually gets absorbed or completely, what is the right word to use? It gets lysed possibly in the next 3 to 6 months. So it definitely used to improve the bleb morphology, and we used to have less incidence of hypotony in the postoperative period, specifically in those patients with risk of hypotony like high myopes, juvenile open angle glaucoma, children, in all of these patients. But during COVID, there was a problem and Ologen is not available anymore. I think its manufacturing was stopped. So there are other newer surgeries that are there. Expression came in, but then it went out of the market. We don't use it anymore. If you ask me, does it really benefit people by making a modification with expression during trabeculectomy? I don't think so. So we have used it when it came into the market because for us to understand whether it will really help or not. But buying a device which is so expensive and placing a metal implant in the anterior subconjunctival space or a subscleral space is not something we would be comfortable doing. And I think less and less number of people are using this device nowadays. The other group of patients, like for example, if you have very high-risk patients for trabeculectomy, or your previous trabeculectomies have failed, then we need to have alternatives. So one such alternative is a glaucoma drainage device. In fact, what was very interesting when I was reviewing the history is that glaucoma drainage devices, although they've become popular in the 1990s, but the use of horse hair to try and create a conduit under the scleral flap from the anterior chamber into the subconjunctival space was tried long ago in 1906. Following which Molteno has brought in an acrylic tube and plate, but it did not do very well because they had used the plate they placed the plate in the anterior subconjunctival space, and many of them used to have an erosion and people used to lose the eyes. So then there came a long silicon tube with a large end plate. I think that in 1973, a modification that was made to the previous Molteno implant definitely had a good success rate. However, the plate was still made of PMMA. And from there, it moved on. And now we don't have a multi-node that is used frequently. What we use now is an Ahmed glaucoma implant designed by Mateen Ahmed. And for information that he is an Indian, I think he belongs to somewhere close to Bhopal. And
Bhopal.
so he moved from here to Canada. He designed a device and that became very popular. And today that is the most commonly used flow restrictive aqueous drainage device anywhere in the world. And George Bawelt during the same time also came out with a non-valved device called the Bawelt implant. And the difference between the Ahmed and the Bawelt implant is that Ahmed is a flow restrictive device. That means it has a valve mechanism that will prevent hypotony in the post-operative period. Whereas the Bawelt implant or the currently Indian model that is available, which is called as ADI or the Oralab aqueous drainage device, both of them are the similar type made of soft silicon material, but they are non-valved, which means they are not flow restrictive. Hence, during surgery, there are certain modifications that are done to provide flow resistance. So, alternate aqueous pathway is created from the anterior chamber into the posterior subconjunctival space. So this word posterior subconjunctival space is very, very important, because if you are using a foreign body or a device, even if it is made of silicon material, you can't have anything in the anterior subconjunctival space. Anything that you put anteriorly, it is likely to erode with your lid movements, even if you're placing it in the subconjunctival or a subscleral space. And hence, if we have to place a device, it has to be in the posterior area. So that is very important. When do we do implants? When the conventional surgery has already failed, or where there are multiple secondary causes where the conventional surgery is likely to fail, in situations like traumatic glaucomas and certain types of uveitic glaucomas, neovascular glaucomas. But again, remember one thing, that unless the conjunctiva is completely scarred or the anterior segment has a lot of still an ongoing inflammation and things like that, even in patients with neovascular glaucoma, even in patients with uveitic glaucoma, even in patients with IC syndrome, where we think the success rates are not so high with trabeculectomy, we still prefer to do trabeculectomy. So I'm not saying all of these indications. My primary indication is a glaucoma drainage device, but often these are the eyes where if they have, let's say, an NVG, but with persistent new vessels, in somebody with posteriorly treated, has a PDR with an associated ocular ischemic syndrome and things like that, where despite all the best efforts, the eye is really, really difficult to, the anterior segment is not very quiet, and this eye requires a glaucoma surgery with completely closed angles. In a situation like that, whether I would do a trab or an implant, maybe I will choose an implant, because the success rates are going to be far low if you have an ongoing inflammation in the eye. So I'm just giving you an example that GDD is still not the primary choice in several of our situations, but we would prefer to do the alternate procedures, whether it is trabeculectomy or one of the mixed procedures that we have today, before we embark on doing a glaucoma drainage device. So in situations where you have a lot of anterior conjunctival scarring, multiple previous intraocular surgeries, somebody with lid abnormalities, all of these situations, we may choose to do a drainage device. So valved implant, this is a short video that shows you how a valve device is used. So valved implant is an Ahmed glaucoma valve, I said. Posteriorly, about 9 to 10 millimeters behind the limbus is where we place the plate, fix it with Prolene suture, and we make a 3 or a 4 millimeter from the limbus, the scleral tract, and place the tube through the scleral tract into the anterior chamber or into the sulcus. And if it is a vitrectomized eye, and if you have an opening when you're doing a simultaneous surgery, we can place the tube in the pars plana as well. And the entire length of the tube should be covered by a patch graft. Some people don't use patch grafts, but personally, although I do a long tunnel, so this was an old video where the tunnel was short. Otherwise, usually I make 3 to 4 millimeter tunnel, and through the tunnel place the tube either in the anterior chamber or in the sulcus, despite which I will still cover the entire tube with the patch graft. because the chances of erosion of the conjunctiva is very, very high, and you don't want to take any chance with a foreign body there. How does that differ? And the conjunctiva is closed, so fluid will start filtering immediately. Whereas for a non-valve device, the problem is, since there is no valve, we have to ligate the tube. This tube ligation is done with 6-0 vicryl suture. I place 1 or 2 complete ligatures with 6-0 vicryl, and the rest of the procedure is the same, except that a non-valve implant, which is the Bavelt or the ADI, has a surface area which is much larger, 350 millimeters square, and hence you can't place it like the AGV, which we do, placing it between the 2 recti muscles, because anteroposterior diameter of an adult AGV is about 16 millimeters, and a side to side is about 13 millimeters. So between the 2 recti muscles, comfortably you can place it. Whereas an ADI, it is 350 millimeters square, a very large surface area, close to about 31 millimeters on the side and 13 millimeters anteroposteriorly. And hence, we have to make sure that you identify the muscles, the lateral rectors as well as these superior rectors, if you're doing it in the supratemporal location, and place the wings in the under the muscles, and that will help to hold it in position, and despite which you will still go ahead and fix the implant with the Prolene suture, and of course the rest of the procedure will be similar. So there are several indications. We can also combine, just like how you do a combined phacotrabeculectomy, you can also do a combined phaco with an AGV or a scleral or a glued intraocular lens with an AGV. So combined procedures can also be done. In certain situations like keratoprosthesis or artificial cornea, if there is glaucoma in these eyes, the only treatment option it will be a drainage implant. Of course, the other treatment option would be to do a cyclodestructive procedure, but if you want a definitive surgery, it should be an implant in these eyes. And to take you through the mixed procedures, I will come to the details in a little while, but I just want to share a couple of slides on the anatomy. In the angle, we all know that there is a scleral spur. This is the scleral spur. Bridging the scleral spur is what you have, the trabecular meshwork. And this trabecular meshwork, from anterior to posterior, you have a juxtacanalicula trabecular meshwork, which is kind of provides a lot of resistance for the fluid to from the anterior chamber to reach the Schlemm's canal in patients with open angle glaucoma. And once the fluid, in case the fluid reaches the Schlemm's canal, from there you have collector channels that connect the Schlemm's canal to the episcleral veins, and it joins into the blood circulation. So in patients with open angle glaucoma, the major resistance of the fluid to reach the Schlemm's canal is provided by the trabecular meshwork. So what we do in most of the mixed procedures or the minimally invasive glaucoma surgeries is to try and remove this trabecular meshwork obstruction so that fluid can directly reach the Schlemm's canal, and from the Schlemm's canal through the collector channels, it can reach the episcleral veins. So they are the procedures that are there. So I'll just skip a few of these slides. So I'll take you through the actual procedures that we do today. Of course, cyclodestructive procedures that we use are transscleral cyclophotocoagulation, endocyclophotocoagulation, and a micropulse laser. So these are not minimally invasive, but yes, they do provide an, to put it in another perspective is that either you can decrease the production of the fluid or you can increase the outflow of the fluids. All the other surgeries that we spoke about are to increase the outflow. However, in certain situations, let's say if it is extremely risky to go and do an intraocular surgery, like I have a patient whose pressures are 50, 60, not going down, despite all oral medications, despite even an IV mannitol. And if I have to do an intraocular surgery in that patient, I will be very, very skeptical, because when you have such high pressures and you cause a sudden decompression, they may end up having a suprachoroidal hemorrhage, and you may even lose the eye. So, or an expulsive hemorrhage. So we have to be very, very careful. So if there is somebody, except lens-induced glaucomas that I'm talking about, but otherwise, if you have somebody with a glaucoma with very high intraocular pressures and has been like that for a long time, then we have to be very, very careful in opening that eye. And I would prefer to do any of the cyclodestructive procedures. So I'll take you through MIGS, which I thought was very important to especially the postgraduates, to have an overview on. So currently, most glaucoma. So for MIGS, you have to remember that these MIGS procedures can only be performed for open angle glaucomas, cannot be performed for angle closure glaucomas. In certain types of angle closure glaucomas, whose angles are not significantly closed but may have synechia in one or two quadrants or a few goniosynechia, you can do MIGS in those patients. But in somebody with a completely closed angles, MIGS is not something that you would look at, because you are treating the angle, and in those patients, angles are anyway closed. So that's very, very important for you to understand before I, take you on through this. So minimally invasive or micro-invasive glaucoma surgery, or MIGS as they are called as, are basically those that are non-bleb.
Risha, in between, probably you can ask questions to the postgraduates.
Okay.
Otherwise, it's becoming a more of didactic rather than interactive.
Sure, sure.
Thank you.
So we can take a pause here, and then maybe I can ask the people what they understood.
Yeah, certainly.
Yeah, sure. So can
we have extra time, no worry for the time. Okay.
Yeah. Okay. So can somebody summarize the surgical management that we have discussed until now?
They can say the types of surgeries.
Yeah. Just the names.
Postgraduates, yes.
Better to ask by name. Anybody means nobody.
I think Bharti, we can call Bharti to answer. Bharti is postgraduate, I believe.
No, Bharti is not the postgraduate. Pooja, Subhasri, they are postgraduate.
Yes.
Okay.
So first, we go for trabeculectomy. With its modifications, like
the very first slide, what did she say?
The types of surgeries that can be done in glaucoma.
Yeah.
One was trabeculectomy with its modification.
Something to do with the thickness.
Yes, sir. Total and partial thickness. First was total thickness.
Complete thickness. Yes. It's not. Yeah. It's not.
Yeah.
Yeah. I mean, both of them are the same, but then you use it in a different context. Full thickness, right?
Full thickness. Yes. Yes, ma'am.
Yeah.
Then partial thickness, we can go for trabeculectomy with its various modifications, like use of antimetabolites with trab, and then we can go for non-penetrating surgeries. Then glaucoma drainage devices can be used, and then we can go for MIGS.
Okay. And anything else?
Well, the express mini shunt was also was being used.
Yeah, and cyclodestructive procedures.
Cyclodestructive procedures.
All right, good. So, can you name the two different types of suture modifications that we can do during trabeculectomy?
Yeah.
Yes, ma'am.
We'll ask some other postgraduate. Pooja told something now, so.
I can't see anybody's name. So
Madam, Dr. Aditya is there.
Aditya is there, yeah.
So, ma'am, the two different types of sutures are adjustable sutures and releasable sutures. So, adjustable sutures are placed entirely subconjunctivally, and we have to adjust them sideways post-operatively to loosen up the sutures a bit, while the releasable sutures, they are a part of it is in the cornea, so that we can basically cut the sutures, and that way we can relieve some of the pressure, and we can also remove the sutures.
We don't cut it, we release it. So releasable sutures are not cut, they are released. They cannot be cut. Why they cannot be cut?
Because they are buried inside the, they are placed inside the cornea.
No.
Oh.
So if it is so for you to cut any suture, it has to be a single suture and it has to be tight, right? And as soon as you cut, it should open up. Whereas in a releasable suture, what you do is you are going to loop it. When you're looping it, you put 4 throws, and when you loop it, and you bring one of the edges to the outside. So if you have to cut, first of all, there is a loop there. Even if you cut, it's not going to open up because the suture is intertwined. Okay, so it doesn't help. You can't cut. It's not possible. When I say you can't, it's unlikely that you cut. But yes, sometimes when you're trying to remove the releasable sutures, it may break. In a situation like that, we can try. But otherwise, tight sutures are always laser suture lysis is performed. Which type of laser do you use to do a laser suture lysis? Anybody else can take it. Although I haven't covered it here, but maybe a good idea if you can.
Yeah. It's better to have that.
Yeah. Which type of laser is used? Any idea?
YAG.
YAG laser. What is the type of laser with YAG?
Photo disruptive.
Yeah. So with that, can you cut a suture?
Probably not.
What is the wavelength?
1046 nanometers.
No.
1064.
Ah. Okay.
All right.
Yeah.
Yeah, so you use green laser or you use a frequency double YAG. Basically, you need a photocoagulative laser that will be absorbed by the pigmented suture that will get cut. Okay, so if you're using the regular tight sutures, let's say I put 3 fixed sutures for the trabeculectomy flap, then I can use laser suture lysis. But if I put 1 releasable or 2 releasables and 1 fixed suture, then it's up to me to plan whether I need to remove it or not. If I need to remove, I'll remove 1 suture at a time. So always it is 1 suture at a time and never remove more than 1 at the same time, because suddenly the eye can go into hypotony and we can even lose the eye because of that.
We can also ask regarding GDD when it will be, they will go for GDD. You have told.
Yeah. Yes, if someone else can take that question, please.
The indication of glaucoma drainage device, when to use.
Who are all there?
Dr. Dinesh is there. So Dr. Dinesh is postgraduate.
I think no.
No.
Sonali, Dr. Subhasri.
Subhasri is there.
Yes, sir.
Yeah, Subhasri.
Subhasri is there.
Yes, sir.
Yeah.
Yes, sir. Yes, sir.
What are the
yes, sir. So glaucoma drainage devices reduce IOP up to very lower extent, and it cannot be used in it has to be used in open angle glaucoma cases where we have to reduce IOP up to a slight bit of extent. It is not a definitive procedure. So if we plan for cataract with reduction of some amount of IOP, we can use DDDs. Otherwise, our mixed procedures are actually
the question was
not irreplaceable with TRAB. They are not replacing TRAB, but just some of the additional IOP reduction it can be done.
The question was for glaucoma drainage device.
Indications for glaucoma drainage device.
Yes.
Please.
I think Subhasri, we are talking about GDD. Sorry, the mix. Right?
Yes, sir.
Yeah, the question was when the GDD should be used. What is the indication, absolute indication for GDD that you cannot go for TRAB and you have to go for GDD?
So what are the two different the basic types of GDDs that we have discussed just now?
Yes.
Valved and non-valved.
Yeah.
Valve.
Very good.
Nice.
What is a valve device?
What is the name of the valve device?
AGV Ahmed glaucoma.
Ahmed.
Yeah.
Ahmed.
And non-valved implant is?
Barwell.
Mm.
And what is the Indian model of that?
Adi.
Adi.
And you can
Adi.
What is the full form of Adi?
Just now she told us.
Made by which lab?
Orolab.
Yeah.
Drainage implant.
Aqueous drainage
Implant.
Yeah. So it's important to know. So what is the suture material that is used to provide the flow restriction for a non-valve device? How do you?
Vicryl.
Yes. What vicryl?
60.
60 vicryl. Very good. It
Nice.
is one. And how long does it take for the 60 vicryl to open up?
2 to 3 weeks.
No.
90 days.
No. So the thicker the suture, so if you're using a 80 vicryl, the way we do for trabeculectomy, it gets absorbed maybe by about 3 to 4 weeks. Whereas the one that we use here, the 60, is a little thicker one, right? So that takes a little longer time. So typically between 40 to 45th day, the ligature opens up, which means it gets mostly dissolved. So it takes 5 to 6 weeks for it to get absorbed. And why we are using 60 and why not any other material is because if you're using, you can use 70 also. 80 will be too thin, but you can use, some people use 70, but we don't like to use 70 because 70 gets absorbed by about 28 to 30 days. So what we want is before the ligature opens up, there should be a thick bleb that is formed around the plate so that bleb provides resistance for the excess fluid to prevent excess fluid from flowing out. Okay, so if the ligature opens up earlier than that, then you have a problem. So to prevent too many complications, let's say when the ligature opens up and to prevent hypotony, some newer modifications we are doing now. Anybody has any idea? What is the ripcord? Okay, so that is an intraluminal stent that we use to stent the tube from inside also, as well as to ligate it from outside, so that when the ligature dissolves also, you don't have a sudden decrease in intraocular pressure. In some predisposed patients, you may have complications. So to prevent that, we leave an intraluminal stent and we wait for a couple of months before we go and remove it, so that there is a gradual reduction of intraocular pressure. Okay.
Ma'am, actually, you discussed hypotony, this part a lot. So they should be, knowing what are the complications possible for hypotony. Why hypotony is, talked so much. Dr. Sirisa ma'am is saying about this, multiple times. So can anybody explain? What will happen to the eye if there will be hypotony? With increased pressure, there will be optic nerve damage, glaucoma. With decreased pressure, what are the possible things that can happen? Anyone, please, can try.
Maculopathy.
Macular.
Very good.
Macular split.
Macular, yeah. So hypotony maculopathy is the most serious complication that we are worried about. And wipeout is also another serious complication that can happen when you have a low intraocular pressure. So when do you call somebody as having hypotony? What is the IOP cutoff?
Less than 7.
Less than 6. 6 to 21 is taken as the intraocular pressure within a range that is all right. But of course, more than 21, it has a very high risk for having a problem. Less than 6, one can have problems related to hypotony. Okay, so that is cut off. So whenever the pressure goes too low, then there can be problems, not just maculopathy, but the more serious problem that we are worried about is wipeout.
So it's a little bit tricky question for the postgraduates. Even if the pressure is 6, till then we'll say, okay, it is okay, normal for that patient. When is the condition? If the pressure is 6, still we'll say, okay, it's not actually hypotony. We're just recording 6, but not actually 6. When it will be possible? Means false recording of low pressure. When it is possible?
There is edema, corneal edema, or thinner corneas.
Yeah, so we should be taking, if there is any history of LASIK surgery that can lead to thinner cornea. Also, you can record low pressure. Anything else, Dr. Sirisa, you'd like to ask, or we should be proceeding for the next?
First of the shallow anterior chambers.
Yeah.
Yeah. So shallow anterior chamber and low pressure and bleb is elevated. What could be the cause?
Quick.
Overfiltration.
Very good. Overfiltering bleb. So shallow anterior chamber, low intraocular pressure, flat bleb.
Flat bleb. Yes. एक हो गया, दूसरा क्या है?
Bleb leak.
Very good. So how do you pick up a bleb leak?
By Siedel's test.
Good. So how do you do a Siedel's test?
We put a fluorescent stain, and we can see the stain getting washed out.
So
that
is there anything else that you would like to add to quantify that? If I blink also, they can get washed off, right?
Yes, ma'am.
Yeah. So then how do you say the Siedel is positive?
Ma'am, the flowy pattern of the stain will be there around the area of leak.
That's okay. So what you need to tell is when you are lifting the lid, without any blink, when you're lifting the lid and when you ask the patient to either look straight or look down, you should see a stream of aqueous that is flowing out, which is actually clearing off the fluorescent stain in that area. So the lid should not be blinking frequently, because if it is blinking, it will bring back the tears again. So when you're not blinking, when you lift the lid up, it should be uniformly stained. But in one area, if you see that the stain is getting cleared off by a stream of fluid that's coming from the area of the bleb, that is called as Siedel's positive, and that is used to identify a bleb leak.
Suppose on post-op day 1, pressure is very high. So do you prefer doing bleb massage on post-op day 1?
Yeah, so just now I told you, if the pressure is very high on day 1, should I just do a massage, or what else do I need to look for? So if the anterior chamber is shallow or flat, if the anterior chamber is shallow or flat and there is high IOP, it has to be what?
No, I think everything is fine. Only the pressure is raised. So you prefer doing bleb massage on post-op day 1?
So if everything is fine, meaning like posterior segment is also normal?
Yeah, everything is normal.
So how is the bleb?
Bleb is not that elevated also.
So the bleb is flat. What I will do is I look for the pupil. If the pupil is round and there is no problem, it may be dilated, it may be small, it doesn't matter. But if the pupil is round and there is no peaking, that means what? There is no blockade of the ostium by the iris, because that also can cause a flat bleb. That also can cause elevation in intraocular pressure. You need to rule that out as well. If it is not clearly visible, then I will put a gonio lens to see if my ostium is patent, and then only I'll go ahead and do the bleb massage. So instead of doing a gonio indirectly, as soon as you see the eye on the slit lamp, you know how the pupil is, and hence you will be able to indirectly say that unlikely that there is any problem. Sometimes, yes, you can do, even day one also you can do a massage. Sometimes, despite this, the bleb may not elevate. Then definitely you need to put a gonio lens to see, is there vitreous blocking the ostium? Is there iris tissue blocking the ostium? Or is there a blood clot in the area of the ostium that is not allowing the fluid to drain? So all these things are very important.
Okay, I think we can proceed. Sirish.
Yeah.
Next part of yours.
Sure. So minimally invasive glaucoma surgeries are basically those that are non-bleb forming. What they do is they improve the physiological outflow pathway. I showed you the picture earlier where we are trying to remove the area of the trabecular meshwork and allow the fluid to reach the Schlemm's canal and from there to drain outside. Because you are not, you are using the conventional outflow pathway, right? So in a conventional outflow pathway, the intraocular pressure cannot go lesser than a certain amount. What is that amount? Can somebody tell? Let's say it cannot go down lesser than a certain intraocular pressure. What is that cutoff? What is episcleral venous pressure? So you cannot none of these can actually, because it's quite a logical thing to think of, right? From the fluid from the anterior chamber reaches the Schlemm's canal, from there to the collector channels, and there to the episcleral veins. So what happens when the fluid has to get into the episcleral veins? So the intraocular pressure cannot come lesser than the episcleral venous pressure, because fluid is reaching the episcleral veins, right? So it cannot be lesser than the episcleral venous pressure, typically, which is about 10 or 11 millimeters of mercury. So that is why all of the mixed procedures have a floor effect. That means they cannot bring down pressure lesser than a certain level. While with a trabeculectomy, you can get a pressure which is as low as 2, 3, or 4 also. So that is the reason why with mixed procedures, hypotony is extremely uncommon. Of course, you can have any complication if you go and goof up during surgery. That's a different issue. But conventionally, you will not be getting the problem of hypotony with these procedures. And like I told, this is possible only in those with open angles, and hence it is not applicable for angle closure glaucoma. So there are several MIGs that are available: ab interno procedures, ab externo procedures. So I would divide these MIGs into 3 basic types. Those that are subconjunctival, which are not typically MIGs, because the minute you go and touch the conjunctiva and you are doing an external opening, then to me it is not a minimally invasive one anymore. But still, if you want to categorize them, you can say there are subconjunctival procedures, Zen implant as well as Pesser-Fro implant. Supraciliary shunts, that means from the anterior chamber, it goes into the suprachoroidal space. So they are CyPass stent, mini jet, and things like that. Even that I'm not going into the details. But the most commonly used mixed procedures today are Schlemm's canal procedures, where you either stent the Schlemm's canal, you do a dilatation of the Schlemm's canal, or you open the Schlemm's canal. So these are the procedures that we are commonly performing nowadays. So prerequisites for mixed procedure and any angle-based procedures is to be able to visualize the angle. For somebody to visualize the angle, because angle, as the word tells you, it is angulated, right? For you to look at the angle, you need to bend the globe as well as eye, as well as the microscope. So that's very important. And of course, you will require a direct gonio lens to be able to visualize the angle. So these are again very, very important with a lot of effort. In fact, we've tried to put together this information as to what the Schlems canal, what are the dimensions of the Schlems canal, are the Schlems canal size uniform in adult patients and in children, and do they change based on the refractive error, do they change based on the glaucoma surgery. So Schlems canal is a circumferential canal that is present all around the limbus. But remember that it is not like a tube. It also has multiple valves. So you may have some restriction of the fluid flow based on the resistance that is there within the Schlems canal as well. Maximum number of collector channels in the eye are present apparently in the infranasal area. That is the reason why when we do any of the mixed procedures, you do it in the nasal area, because nasal has maximum collector channels and the mix are likely to work much better when you're doing it in that location. So the commonly performed mixed procedures are GAT, which is the gonioscopy assisted transluminal trabeculotomy. This is an ab interno procedure introduced by Devinder Grover in 2014. What we do here is we use 50 proline suture with a umbrella tip, and we try to thread the Schlems canal 360 degree and try to open up the inner lip of the Schlems canal or the inner wall of the Schlems canal into the anterior chamber. And by doing so, we are allowing free access of fluid from anterior chamber into the Schlems canal. So I'll just run a video. So this was a young patient who had a post-vitreoretinal surgery and who had uncontrolled glaucoma, had undergone an implant. Post that again, his pressures were uncontrolled, had developed a cataract. So I had to do a wash of the anterior chamber and do a cataract extraction along with mix. So what we do here is that you open up a part of the Schlems canal and you're using a 50 proline suture to thread the Schlems canal 360 degree. And once the suture comes onto the opposite side, you're holding it and trying to rip open the inner wall of the Schlems canal. So this patient, this boy, he was a young boy, he's about 24, 25-year-old, who had an RD, underwent a scleral buccal 360 degree plus plus a vitrectomy. He had a giant retinal tear. And with all this, his retina got settled, his vision was 20/25, but he had uncontrolled pressures. He underwent an AGV. Post that, again, his pressures were not controlled after about a few months. And we had no choice but to go ahead and do either a trabeculectomy. But in this eye with trabeculectomy with a 360 degree buccal, it's not going to be very easy. If not, you have to either do a TSCPC or a one more implant. So to avoid that, we thought if we can give some other alternative for this young boy, it would be better. So he underwent a GAT, and currently his pressures are well controlled, and he is just on one combination medication, and his vision is maintained. All of this when disc is healthy. So this is the picture that shows you a trabecular shelf. After the mix has been done, you'll see that cleanly the entire pigmented portion of the trabecular meshwork is removed. So the GAT seems to be not just helping those patients where as a primary procedure, but it also seems to be helpful in patients who have undergone previous glaucoma surgeries, like either a trabeculectomy or an implant surgery, and the surgeries have failed. You can offer them, instead of doing one more implant or one more trab, you can definitely offer an angle-based procedure in them. So we do have some experience in these patients over the past few years, and we are seeing very encouraging results in these patients. Another one that is commonly used is called a Kahug dual blade goniotomy. So what it does is it has a blade which has a sharp tip. It has a ramp with two edges on both the sides, and then there are dual blades. So what this does is you go and engage the trabecular meshwork and try to rip open the entire trabecular meshwork and remove it. So you can, most of these MIGs are usually combined along with cataract surgeries, and after you finish your cataract surgery, you can go ahead and do the angle-based procedure with either the GAT or KDB or one of these. So BANG is also one more procedure with that we are using. The prerequisites are that the eye should be bent away from the surgeon. The microscope should be bent at least by 35 degrees towards the patient. You use a direct gonio lens, which is a Schwann-Jacob lens, which is what I'm using right now. And we can do a goniotomy about 90 degree, 100 degree or 120 degree on either sides. We do expect some bleeding in these patients because the minute you open up the inner wall of the Schlemm's canal, of course, there is bleed. The fluid drains into episcleral vein, so there will be a reflux of blood that comes outside, and that can be sometimes very disturbing. So our initial experience seems to be quite encouraging. Another one that is commonly done as because KDB again I think is about $200-300 and it's possibly a single-use blade, so you don't want to do that. But nowadays we are using a 26 gauge needle and bending it in the opposite direction, opposite to that of what you do with a cystitome, and you are using this to go and remove the pigmented part of the trabecular meshwork. By doing that, you are opening up the area of the Schlemm's canal directly into the anterior chamber. Other procedures that are done are called iStent, iStent inject, and iStent supra. But they are quite useful. They are easy to insert, but a cost is something that one needs to account for. Maybe I can just show that video. So once you identify the trabecular meshwork, so you use this iStent, which is on a long handle, and you go pierce the trabecular meshwork and leave it there, tap and see so that it is not, the snorkel that is sitting there is not going to fall away. Post-operatively, they have very minimal bleeding, eye is quiet, they recover so well as it can be repeated as well. So, but usually iStent is not a single iStent is placed. Sometimes 2 or 3 different iStents, 2 or 3 locations also iStents are placed. So I'll take you through another. Yeah. So this is just a chart for you to know the complexity of the surgery as well as how. Let me go here. So if it is a easy surgery to do, but it is very expensive, it's not going to help the common man. But if it is a cheaper surgery, but it is not so effective or has complications, that is also not going to help. So if you say ease, three stars here means it's very easy, but it is very expensive. GAT just has a single star, which means it is not easy to perform. But if you look at the cost as well as the efficacy, that is the highest. So that is something that we need to remember. So in choosing mixed procedures, you will not want to do this for angle closure patients, for those with advanced glaucoma, or those with progressive glaucoma, those with very high intraocular pressures. You should try and avoid them. And you would want to choose these mixed procedures in patients with open angle glaucomas, where they may or may not have high pressures depending upon the requirement. And you have to remember that you are not going to bring down the pressures to a very low level. Okay, so I would just say that there are several mixes that are available in India, but they can only be performed in open angle eyes, and they do have a learning curve. One has to choose the patients really appropriately before embarking on these surgeries, and they have very, very few complications that are also self-resolving. So to summarize, I would say that surgical management of glaucoma has a huge range of surgeries to offer, especially in today's day and age. It is very, very encouraging and possibly the best time to be in the glaucoma service, I guess, where there are newer types of surgeries that are available, where at some point in time, when I was thinking I need to put in a second implant and even my second implant has failed, what next? I think the mix is definitely changing that trend, and possibly it is falling in between the trabeculectomy and implant, or even after the trabeculectomy has failed or the implant failed. To a great extent, we are able to see reasonable results in these patients. The cyclodestructive procedure, like I mentioned, has a role to play, but it is very limited because of its unpredictiveness, and we do not know how much IOP will reduce in each of these patients. So it is usually reserved for eyes where they are very high risk for any intraocular surgery, or it is a non-seeing eye to relieve pain and intraocular pressure. All right, thank you. So maybe we can go in for some questions. If somebody can answer what are the 3 broad types of MIGS that we see.
Postgraduates, they are silent.
No,
They're off. They're off or Aditya?
Yes, sir. So one is through improving the flow through trabecular meshwork. We either open up the trabecular meshwork and increase the flow through Schlemm's canal, or place a shunt into the subconjunctival space, which are not exactly MIGS, I would say, as ma'am said. And the other is they increase the pathway through the suprachoroidal region.
Very good, fantastic. Okay, so the most often the procedures, the group of procedures that we perform are the Schlemm's canal based procedures, right? So can somebody else name them? What are the Schlemm's canal based procedures?
GAT. And another one is eye stent. Then ab interno canaloplasty.
Ab interno canaloplasty, I'm not sure what that is, but
Cahuck dual blade.
Yes, Cahuck dual blade. Very good. What do we do with the 26 needle?
Yeah. By bending it stiff, we can use it to scrape the inner wall of Schlemm's canal.
Yeah, so we
just like Cahuck dual blade.
Yeah, so you don't use the term scrape. We are not scraping, we are excising. Okay, so broadly, in fact, even these are divided into incisional goniotomy or an excisional goniotomy. Incision means you are just giving an incision with an MVR blade, or you are just giving an incision with any other sharp instrument, right? So that is incisional goniotomy. Even GAT, for that matter, is an incisional goniotomy, although you're doing it 360 degree. Excisional goniotomy is the Cahuck dual blade as well as the bang, or sometimes another technique that I had not mentioned here is trabectome. What they do is they go and literally open up the entire trabecular meshwork, right? So that is they're excising the trabecular meshwork completely. They are removing that portion of the trabecular meshwork, and usually it is done about 100 to 120 degree, not more than that.
Where we have to reduce IOP up to a slight bit of extent. It is not a definitive procedure. So
yeah, so rather than saying not a definitive procedure, what I told is, no, it's not like that, because nowadays we are using MIGS more often to even patients for whom you are operating for the first time. So it's not like it's not a definitive procedure, but it cannot bring down the intraocular pressure to as low as what a trabeculectomy can do. For example, if I have, let's say, somebody, let's say it's a patient with open angle only, but if that patient is progressing and progressing at 15, 16 intraocular pressures. Now I want to make sure that I want to prevent progression for this patient. I want to bring down the intraocular pressure to as low as possible. That means I want to bring it to as low as some 8, 9 like that. So if I have to get the intraocular pressures to a very low level, MIGS are not the choice. Okay, so typically in somebody with a progressing glaucoma, you don't want to do MIGS. But if somebody with high pressures or somebody with controlled pressures but is on 3, 4, 5 medications, then it may need a cataract surgery at the same time. So in those patients, doing MIGS is definitely an option. We can also offer this to children. I have not included the children's surgeries today, but we can also offer this to children, both in patients with developmental glaucomas as well as in those steroid-induced glaucomas. It is very, very useful.
knowledge and a lot of information that you have really shared. So to the postgraduates, can you just tell us, like ma'am has already explained regarding the use of MMC and 5-fluorouracil. So what is the concentration of MMC being used? And madam has already explained what are the precautions to be taken for using mitomycin C, which are the patients whom they should be used more and whom they should be used less. Anybody like to share, because this is, I think it's a very common question in the postgraduate exam.
It is 0.02% mitomycin C is used.
So when it is not used?
It causes scarring and fibrosis of the bleb, so leads to its thinning.
That mitomycin causes scarring or fibrosis, or it is used to prevent scarring and fibrosis?
Sorry, ma'am, it's used to prevent fibrosis and scarring.
Mitomycin C is originally which drug as per the pharmacology classification?
It is an alkylating agent.
Yes, and it comes under the group of anti-cancer. Yeah. Okay, so where it is used more? Which disease that ma'am has already explained, like in which conditions it is the use of, like the duration she has mentioned, no? So what are the precautions she has told that you should be taking care while using the mitomycin?
Should be washed properly, adequately.
Very good, very nice. And what else during application?
It should be applied to a wider area.
Perfect, nice. Okay, good. Dr. Sirisa, anything else you would like to ask?
Yeah, I think they are fine. So if it going to the only request I have is it shouldn't be like today you have learned and this is all that you would want. I think this should be a stimulus for you. There are so many videos available on the YouTube. Go and choose them and watch those procedures, because if you have to go through and show you videos, I mean, these are all edited and speeded up videos because there's not much time to discuss everything, right? So I think it will be a good idea to go and watch all of that. That will be very, very useful for you, not just for your exam, but also it will give you an opportunity to know, offer a treatment for your patients also.
Sirisha ma'am, it was a very fantastic and informative lecture, ma'am. Ma'am, I just have one question, ma'am.
Yes, go ahead.
Yeah, ma'am, just wanted to ask, like, what about 5-fluorouracil? Like, in my PG post-graduation days, we used to give 5-fluorouracil injections near studies also. Many.
I think someone is
someone's audio is on and they are
speaking, so it's disturbing the other asking questions. Please mute it. Yeah, so it's a very important question and I think very relevant. I could not touch upon a few things because of the time, but 5-FU is also a wound modulating agent. Typically, it is not used during glaucoma surgery or during the trabeculectomy, but it is used in the post-operative period. So whenever there is a fibrosis that is setting in, if you see that the bleb is angry looking and has corkscrew vessels, it's not very elevated, it's kind of inflamed. In situations like that, we give 5-fluorouracil, and usually the injection is given in the opposite quadrant. So superiorly, if you have the bleb, typically this injection is given in the inferior quadrant. And depending upon how much of inflammation is there, one may want to give only 1 or 2 or 3 once every day, or once alternate day, or once a week, based on how the bleb is responding. So we do that, but it's very, very rare. I don't do that frequently. But very rarely I may have to use my 5FU. But yes, it definitely has a role to play. But during primary surgery, there are head-on studies that have compared the two. MMC is far superior compared to 5FU during surgery. So we don't use 5FU during surgery. It's only in the post-operative.
Yes, ma'am. I've gone through few research studies, ma'am, where they have mentioned the use of 5FU with infrared something like what is the connection of that infrared use?
Not infrared. What I understand from what you're saying is possibly something to do with beta radiation.
Yes, I think that.
Yeah. So the beta radiation is something that is very what do you say, localizedly used by people in Moorfields. So where Professor Penko's group, they do it. Basically, it is again something to do with prevents fibroblast proliferation and helps to modulate. So nobody else anywhere else in the world actually uses it, but they use it and they find that it is helpful.
Okay, ma'am. Thank you so much, ma'am.
One question, ma'am.
Can I ask a question? Hello.
This is Dr. Shiraz.
Yeah.
Yeah, Dr. Siraj.
Dr. Siraj was asking, and then after that, there's
Dr. Richard.
Yeah.
You can proceed.
So post-TRAB patients, steroids are very important after trabeculectomy. So some patients are high steroid responders. So how do you tackle these patients?
Yeah, so that's a very, very important question. So there are two issues here. Post-trabeculectomy, let's say the right eye is operated and left eye is not operated but is on anti-glaucoma medication. So now the operated eye, I've stopped anti-glaucoma medications. We put them on topical steroids. That same eye may or may not have steroid responsiveness. If the bleb is filtering very well, they seem to be okay, but they can have a contralateral steroid response. So the contralateral eye, which was on anti-glaucoma medications but relatively well controlled before, now when one eye is operated, the pressure starts shooting in the opposite side. That could also be because you may have given Diamox pre-operatively and then Diamox is stopped now and then the contralateral eye pressures may go, but typically it happens because of the steroid response. On the other hand, even in the same eye, you may have elevated intraocular pressure, but if you have a nice filtering bleb, you don't have too much of inflammation, but still your pressures are high, you will think of a steroid response possibility, switch from prednisolone to loteprednisolone. And there are very rare instances where I have at least 2 or 3 patients I can remember for whom even lotepred I had to stop and put them just on non-steroidal anti-inflammatory. But that is rare. Like I would say in 22 years, I may have required to do this for about 3 patients or so. But otherwise, I switch them to a low potent steroid, and of course the frequency also can go down. Instead of 6 times, I may make it to 3 times or 4 times or whatever, but then I taper, and sometimes this is seen by about 3rd week or so. By 3rd week, if your bleb is good and things are fine, then you can very quickly taper it every 2 days or 3 days and stop the drug. But yes, that is a challenge in these patients.
Yeah, definitely, ma'am.
Yeah. And the challenge is far higher with MIGS. It's far, far higher with MIGS. So I would say this typically the steroid responsiveness that you see following MIGS can be 10 times more or even greater compared to trabeculectomy. Yeah, Dr. Richa had a question.
Yeah, ma'am, it's a pleasure always to listen to you. I had a question to the postgraduates, Dr. Pooja, Dr. Aditya. So Ahmed has come up with a new valveless implant. Can you name it? So typically the AGV is a valve implant, but there's a new valveless implant it has come up with. So it's called Clear Path. Ma'am, I just wanted to know your experience with it. How was it?
Yeah, so Ahmed Clear Path is, again, the dimensions are almost similar to that of an AGV, and it is a non-valve device. So we use a proline suture to stent it. and it is okay. I mean, I would say between an ADI and ACP, which one would you choose if suppose there is too much of a scarring and I cannot isolate the muscles so that I can't place the wings of the ADI under the muscles, I have difficulty doing that, then I would prefer to use an ACP. But if I want a larger surface area, less expensive one but more effective, then I would use an ADI. So that's how it is. But otherwise, ACP is about 25,000 rupees and ADI is about 5,000 rupees. So it's not just the cost alone, but the efficacy also. So earlier it used to be a problem when we are using the ADI without the ripcord. Without the ripcord, we used to have problems. Hypotony used to be there when the ligature opens up, but with the ripcord, we seem to have better results. So for me, I choose ACP in a very, very few situations.
And how useful is it for the postgraduates to know the bleb grading? Like, do you do it in your normal day-to-day practice? Or do you recommend the youngsters to actually know about it?
Yeah, so there are two types of bleb grading systems that people should know about, the Indiana bleb grading system as well as the Moorfields bleb grading system. So typically, I think it's a good idea for the postgraduates to read because they may have an exam question as well. So as you keep looking at the blebs and once you know that there is a type of grading that is available, so you will, basically it will help you to understand, is it going towards fibrosis, is it overfiltering, or is it likely to have a thin cystic bleb and fail or have complications and things like that. So the height of the bleb, the vascularity, the thickness of the bleb, the extent of the bleb, all of these are very, very important for us to grade. So I think it will be a good idea for the postgraduates to read the different bleb grading systems.
Ma'am, I want to ask a question.
Yeah, yes.
After a patient undergoes phacotrab, is it wise to continue with the anti-glaucoma medication? And if it is wise, which one we should use, ma'am?
No. So if the pressures are well controlled, of course, we are not going to start them on medications. But if the patient's pressures are not very well controlled or they are controlled, but they are borderline, and you feel that for the amount of damage of the disc, you may want lesser pressures, then you can add anti-glaucoma medications. So I mean, I would not shy away from adding anti-glaucoma medication. So again, I don't have any preference. I would say I would use a beta blocker because it's less expensive and I'm okay with using it. PG analog, suppose I want to use it only for one eye, then I would be skeptical a little bit. So I would use a beta blocker. And if the pressures are on the higher side, it's just one drug is not sufficient, then I don't think I will really think. Whatever is available and what patient can afford, I think I would use, not an issue. But if one drug you ask me, I would start with a beta blocker.
Thank you, ma'am.
Any other questions from the panelists or discussants? Please, you can go ahead.
I think it is.
Yeah, I think we are just, come to an end, and a very good discussion today it has happened. So I will like to invite our Chairman Scientific Committee, Dr. Sabyasachi, for concluding remarks.
So excellent session indeed. Thanks, Dr. Senthil, for the extensive discussion on a topic which is very close to all of us, and the postgraduates also need to learn for their exam and also for practical handling the glaucoma cases in their future practice. So this is certainly a very informative talk for the general ophthalmologist, also those who have attended this program. So thank you very much.
Thank you, sir. Now I would like to invite our Chief Coordinator, Dr. VNR Subudhi, sir, so to give a vote of thanks.
Thank you, Anindya. I think it's a really wonderful seminar today. And Dr. Siris has well explained. I thank her for coming twice to our ORTS program. And we're looking forward to have you again in future. So thank you very much. And thank you, our President, Dr. Pranabji, is sitting since the start of the program. And
So
of
this
course,
is-
our panelists, really the great, good panelists today. We have interacted very well with the students and also with each other. And last but not the least, our students. Today, I think they have opened up very much, but still I'm shocked to see that they are not coming with the videos. So most of the people should come with the video. Just we are insisting every time. So next time, I think we wish them to come with the videos on. And thanks, Dr. Anindya, moderating very well. And thanks to all viewers. Before I close, I will ask our host today to play the video. Usually we play. Rahul is ready? Video is ready? Mr. Rahul? Yeah. Thank you all. Thank you all. Good night.
Final comments from Dr. Ajit Babu sir, mentor, please.
Good night.
Thank you,
Good night all.
Sirisha.
Thank you so much. Thank you so much.
Thank to all. Thanks goes to our mentor, Dr. Ajit Babu, selected a good speaker today. And I think his speaker selection is really excellent.
So it
Thank
was-
you, Dr. Ajit Babu.
It was absolutely amazing and absorbing.
Thank you, sir. Thank you.
All the efforts are the speaker's efforts, nothing from my side.
The choice also
You
is
should appreciate only Sirisha.
Sir, the choice is also important, sir.
Yeah, selecting a good speaker is very important, you know.
Right. Good night.
Okay, good night.
Good night.
And,
Good night,
next
sir.
time we are going for
Good night, sir.
ophthalmoplasty.
No, Dr. Anindya also done her job.
Very well. Yeah. Anindya has really
Engaging the postgraduates in discussion.
not
Actually,
only that, she was very active all through.
she actually stimulated the postgraduates to open up today. So, thanks.
Thank
This
you,
is our
sir.
last session on glaucoma, and we'll moving on to ophthalmoplasty.
Ophthalmoplasty.
Yeah, thank you.
Sharmishta is very enthusiastic about it.
Thank you, sir.
She thought my specialty is coming. Okay, good
Good
night.
night, sir.
Sirisha, thank you very much.
Bye,
Good night, all of you. All
Thank
the
you,
best.
sir. Thank you.
Thank you
Good night,
all.
Dr. Sirisa. Bye.
Nice.